Oh,
you
it's
are,
me.
You are up.
Okay, since I'm going to not thank myself for giving myself this talk, I'm going to just extend my time by 2 minutes. Thank you. Okay, so I'll be talking about the 4 pillars of heart failure guideline-directed medical therapy. Which do I initiate first? So I want to quickly just talk about the 4 pillars, and I want to do this in a historical manner. So starting with the first medications that were approved for heart failure, and then to the most recent. So starting before 1985, way before I was born, they were using just digoxin, I believe, for heart failure therapy. So in the 80s and 90s, we had our ACE inhibitors come up first. And the consensus study actually showed a 27% reduction in all-cause mortality with the ACE inhibitor. And then followed by that in the 90s and early 2000s were your beta blocker trials, and the beta blockers were approved. And there was a meta-analysis of 2 of these trials that showed a 34% reduction in all-cause mortality. And then followed by that, there were the MRAs, your spironolactone and eplerenone, in the 90s and 2000s. And one of the trials, the Rawls trial, showed a 30% reduction in all-cause mortality with spironolactone and a 35% reduction in heart failure-related hospitalizations. And then you also have your angiotensin receptor blockers, your losartan, valsartan, candesartan, which were approved in the 2000s as well, followed by your ARNIs, your angiotensin receptor neprilysin inhibitors, your Entresto as we know it. The Paradigm Heart Failure study actually showed a 20% reduction in all-cause mortality and heart failure-related hospitalization. So this and reduction in heart failure hospitalization, is important because this is what gave it a higher level of recommendation than the ACE inhibitors. And then now we have our new kid on the block, the SGLT2 inhibitors, your Farxiga and your Jardiance. And the meta-analysis of the DAPA heart failure and the Emperor Reduce trial showed a 13% reduction in all-cause mortality and a 25% reduction in heart failure-related hospitalizations or CV death. So guideline-directed medical therapy traditionally was implemented in the order in which they were approved for heart failure treatment. So your ACE inhibitors, your beta blockers, your MRA, and then with the Paradigm Heart Failure trial I just spoke about, we switched the ACE to the ARNI, and then your SGLT2 inhibitors. Now we have some different, Now we have some different approaches that we can take to this. So we have a rapid sequencing strategy where we can start 2 medications, followed by the other 2 medications, and then up titrate both of them really quickly within 2 to 4 weeks. We can initiate all 4 medications, all at low doses, and then up titrate them pretty quickly. Or you can do a patient-centered approach, where we look at the patient and we see what is going on with the patient. Does the patient have chronic kidney disease? Do they have hyperkalemia? Do they have any arrhythmias that I could use one of the medications for? What is their blood pressure? What is their heart rate? So the question that I've been posed is, which strategy do I initiate? And I think, as multiple other speakers before me mentioned, cardiogenic shock, heart failure, I don't think there's a one-size-fits-all kind of answer. So what I do like is the 2022 AHA, ACC, and HFSA guidelines for heart failure management, and so I'm just going to talk about these really quickly. They focus on primary and secondary prevention of heart failure, and their recommendations are based on 2 things. 1, how the patient feels, and how the patient looks. So how you feel is your NYHA classes and the stage of heart failure that they're in. Stage A, they did make some changes, so I'll just mention it real quick. Stage A is the patients that are at risk for heart failure. This is your patient with all risk factors, hypertension, diabetes. I think I'm at risk because I work for heart failure, sorry. Stage B, what they call pre-heart failure, is someone who has structural heart disease but no symptoms at all. And stage C is someone with structural heart disease who has had symptoms or has symptoms, and stage D is your advanced heart failure. And I knew that that was going to happen. All right, and how you look is your ejection fraction. So in heart failure, we love the alphabet soup. So we have HFrEF, HFpEF, and now we have these 2 fairly newer ones. One of them is the heart failure mildly reduced EF, and you have heart failure with improved EF. So heart failure with reduced EF is your EF less than or equal to 40%, which we know. Your mildly reduced EF is your EF between 41 and 49%, and or evidence of provocable or spontaneously increased LV filling pressure. So this is with your biomarkers, with your BNP or pro-BNP, or even hemodynamic assessment. And your heart failure with improved EF is an EF that was less than 40% prior and now has an EF greater than 40%. And your heart failure with preserved EF is your EF greater than or equal to 50% with evidence of increased LV filling pressures. So really quickly, let's talk about HFrEF. We talked about the quadruple therapy, the 4 medications that we talked about. What are their recommendations? They say step 1, start all 4 medications simultaneously or sequentially guided by clinical factors. So what are these potential clinical factors? So you could have advanced chronic kidney disease, so the patient can have advanced chronic kidney disease, and you can consider starting an RNA or an SGLT2 inhibitor first. Patient can have tachycardia or ischemic heart disease. You can consider starting a beta blocker first. Or a patient who's had recurrent hospitalizations for decompensation. They have NYHA class 3 symptoms. You can start with your SGLT2 inhibitor, your ARNI, your MRA, then followed by your beta blocker so that you can decongest the patient a little bit. I do want to mention here, and I know that Jordan spoke about the perfusion status of the patient, so you just want to be careful when you're doing these beta blockers that you can identify that your patient is well perfused. If they're poorly perfused and you want to hold off on your beta blocker, wait for that perfusion status to get a little bit better because it is a negative inotrope, and I think Dr. Wald had mentioned earlier, don't treat the tachycardia with beta blockers. And then step 2, optimize medication dosages. The key for this is for it to be done within 2 to 3 encounters and not delayed beyond 4 to 6 weeks. Now, those of us who work in the clinic setting or in the outpatient setting, we know how hard that is to get these patients in that quickly and that consecutively so many times to be able to do this within 4 to 6 weeks. Step 3 and 4, if the patient has continued symptoms, you add hydrol and nitrates for your African American patients, and then consider device therapies like defibrillators and cardiac resynchronization therapy for if they qualify. And step 5, consider additional therapies such as Corlinor and Vercuvo. Heart failure with mildly reduced EF, I'll quickly just say, same quadruple therapy, but SGLT2 inhibitors do have a slightly higher level of recommendation than the following medications. Heart failure with improved EF. Do not discontinue guideline-directed medical therapy once the EF has improved. I think one of the things I want to mention is what I see a lot, patients get admitted to the hospital, we discontinue their GDMT for whatever reason that's going on. But that's not the recommendation. We want to continue these medications unless absolutely necessary to hold them, and then restart them pretty quickly during that same hospitalization as soon as the patient is clinically stable. And then heart failure with preserved EF, again, I'll mention SGLT2 inhibitors have a slightly higher level of recommendations, followed by your ACE, ARB, ARNIs, and your MRAs. But one thing I will say, no beta blockers are part of guidelines for heart failure with preserved EF. They can have other disease processes, ischemic heart disease, atrial fibrillation that they need beta blockers for, but not for the heart failure with preserved EF. So by the recommendations based on by the stages, stage A, you want to make risk factor modifications, control the blood pressure, control the diabetes. SGLT2 inhibitors actually have a class 1 indication, class 1 recommendation for patients with cardiovascular disease and diabetes type 2. And then you can do your natural uretic peptide biomarker screening. Stage B, these are your patients with a change in LV function but no symptoms. You do same recommendations as what in stage A, but if their EF is less than 40%, you want to initiate their ACE inhibitor and a beta blocker. Stage C and D, same recommendations as heart failure with reduced EF. So I will say, we talk about the 4 pillars, but are they really 4 pillars? What about the hydrolazine and nitrates? I briefly mentioned them, and the recommendations are after optimal medical therapy. You can see that highlighted in red, or for patients who are not tolerant to these medications because of intolerance, because of side effects, or because of renal insufficiency. What about Corlinor? What about Vercuvo? The recommendations, again, after guideline-directed medical therapy has been optimized. And what about INPEFA? INPEFA is an SGLT1 and 2 inhibitor. There were these trials, Soloist WHF trial and the SCORE trial, where the FDA approved the medication for heart failure patients or patients with type 2 diabetes and chronic kidney disease and CV risk factors, although they haven't quite yet made it to the guidelines. But I think it is something that's coming along the pipeline. We need a little bit more information on safety and efficacy of this medication. So what's the bottom line, Neha? The key is to initiate GDMT during the hospitalization and optimize within 2 to 4 weeks. So I talked about the historical guidelines. Since 1985 all the way to 2024, we have approximately can show a 73% reduction in mortality with all 4 medications as compared to no medications at all. And I think that's a huge jump from what we were dealing with. And you can see on the graph on the right that the first line there is with all 4 medications, it does reduce all-cause mortality significantly. And For me, I think this doesn't mean just all 4 medications. I think it's all 4, all 6, or all 8. Don't stop at just the 4 if the patient still has room for more. And that's 15 seconds left. Thank you.
So Neha, fantastic tour de force review. Big topic and excellent job. Let's jump right into questions, and I do want to encourage discussion amongst those in the audience. While we maybe have a question coming, I will ask you about beta blocker use. It comes up, right? When do we hold the beta blocker in the setting of acute decompensated heart failure? And when to start a beta blocker? Either restart or initiate in the setting of acute decompensated heart failure.
That's a good question, doctor. You said I should ask you.
I'm happy to weigh in, but let's
Well, I think for me, a patient who comes in to the hospital who is decompensated but is doing well, we have good perfusion, their blood pressures, not just their blood pressures, but they're perfusing. I think leaving their beta blocker is okay. Maybe if they're in a very decongested state, we just cut it in half. Instead of stopping it completely, because it takes so long to be able to build them up back to that, carvedilol 25 milligrams twice a day that they were on. And then, of course, if a patient is coming in with shock, I think that's a scenario where you would want to hold the beta blockers.
Yeah, I think that's a fantastic answer. And so if you're in Sky Stage C with tissue hypoperfusion, especially coupled with hypotension tachycardia, holding the beta blocker is very reasonable. Those patients that are pre-shock without tissue hyperperfusion or otherwise stable, good perfusion and end organ, we think continuing the beta blocker is just fine. And when you think about the beta blocker trials, these are all outpatient trials. And when we did these, we wanted to ensure patients were euvolemic prior to initiation. So you really want to use beta blockers when patients are more euvolemic in the hospital setting, outside of vasoactive IV drug use. Then you can certainly add low dose, and there's some things we can talk about how to optimize beta blocker utilization. So we're in agreement. Okay. Question over here.
Neha, you did a really, really great job. Thanks. That was really impressive. So there is a lot of attention and a lot of importance associated with getting patients on highest tolerated doses of GDMT. What we're seeing is obviously clinician inertia, patient inertia issues with getting patients on maximally tolerated doses. And I say that because one of the issues that we're having in our institution, and curious if others are hearing this, and curious to hear from the panel what the data is we're seeing euglycemic DKA in our patients who are on SGLT2 inhibitors. And they're coming into the ICU after a brief illness with euglycemic DKA, and our colleagues in endocrinology are stopping SGLT2 inhibitors at that point. And so from heart failure, it's creating some issue. Curious if you all have perspectives on that input or if you're experiencing that as well.
Well, I think I mentioned it earlier. I think there's always a complex interaction between all the different specialties that we have to use. I think the heart affects all of the organs, and so I can't say specifically, I don't know if anyone else wants to chime in, that I've had any such issues. I know getting patients up to that maximally tolerated when I was looking up these guidelines, the reason that I presented this was because I don't think a lot of our patients get through all 4 maximally tolerated, optimized GDMT before discharge. I'm just not seeing it. And I think it's, we should go slow, and should we not? They were just tenuous, they were just in the ICU, they were just in shock, So I think those are a lot of the conversations, but I think that's why this is important, is we've seen it, we can do it, we should push for it, because the mortality reduction is there, and that we should do it.
Anybody else want to weigh in?
I think we end up holding off on SGLT2 initiation until a day before the patient leaves. That's like the last thing we put on.
And then you don't know if they can afford it, so you just put it on
yeah.
and then go home, and they're like, it's $300. Okay, great.
Yeah, we haven't actually had that many issues with cost, and I don't know if that's a
California
state. Yeah.
But I think one of the take-home messages is it's safe to use in presence or absence of type 2, concern about type 1, especially in the context of metabolic acidosis and GFR under 30. But for the vast majority, I have not seen major complications with even early use of SGLT2. So let's jump into additional questions.
Hi, I'm Jill. I work in CVICU at Medical Center. And my question was, you touched a little bit on the holding the beta blocker, but what about your ACEs and your ARBs and your patients going to OR requiring pumps where they have a high risk for vasoplegia post-op? Are you seeing a lot of that? Are y'all continuing the ACEs and ARBs?
So I work for heart failure. If our patient is on heart failure medical therapy, there's a lot of discussion before they're going to the OR. So yes, our surgeons and our team does also like to hold ACE inhibitors before patients go to the OR. But if they're coming in for a decompensated state, we're not necessarily holding them unless we're seeing any hypertensive issues.
Excellent question over here.
Yeah, my question, thank you so much. Excellent. It was great to see all the trials as well. My question is with HFpEF, maybe we don't need beta blockers on some of these patients? Is this what I was hearing?
Yeah, so beta blockers are not part of the guidelines for HFpEF. Now, patients have other medical illnesses, like I said. They could have ischemic heart disease, they could have atrial fibrillation, they could have had VT at some point that they're on beta blockers for, but not for heart failure with preserved EF. It's not part of the recommendations right now.
Right. No, I know, so most of our patients don't just have heart failure. They're usually more complex than that. But I wondered if anybody, and Dr. Estep, maybe you can weigh in on that, if you ever DC the beta blockers.
So yeah, there is evolving data that maybe even beta blocker use patients don't do as well because their heart's not as remodeled with the exception of maybe some LVH, and it's all about stroke volume and output. So I'll use beta blocker and HFpEF for AFib rate control, or they have underlying ischemia. But outside of those two scenarios, it is not first line, right? For the HFpEF patient population, in terms of the best outcome, it's SGL2 followed by ARNI. And so I'll use those. But if I have refractory hypertension or AFib with difficult control rate, or some concern about underlying ischemic disease, the beta blocker is a fine choice. It's just not a recommendation for all, as is SGLT and ARNI use, the two FDA-approved drugs for HFpEF.
Okay, thank you.
Excellent question. We will squeeze in the last question over here.
Hi, Katie. I'm a nurse practitioner in advanced heart failure at UTHealth. We are really struggling that 4 to 6 week period. We can't get patients in. I was wondering if any of your centers utilize telephone nurse protocols, pharmacy-led protocols, anything along those lines.
So since I started working on this talk, I have not been back to work. But as soon as I get back to work, my clinic manager, we will be talking about, I think, heart failure trained nurses doing this. I think there was a lot of research, a lot of take on it, doing this because we can't get them into the clinic. I mean, it's just, we're already seeing, 30, 40 patients in half-day, full-day clinics. Bringing them back in 2 weeks, the nurses laugh at me and they say 2 weeks, your next opening's in June. So, it's one of those things. So I think doing phone triages, having these heart failure trained nurses in the clinics, calling them, titrating their medications in conjunction with an advanced practice provider and doing it. I think that's the best way to do it, and that's why I think I wanted to highlight and keynote that this needs to be done quickly and not at the next follow-up, which will be at 6 to 8 weeks or 2 months or 3 months. That's my personal.
No, agree. I think it's critical, and many systems are implementing disease management platforms, leveraging pharmacy, virtual visits, touch points within 7 days as part of the standard minimization for readmission, but linking it to optimization. Because you're right, there's a dose-response efficacy relationship, in particular for the beta blockers, for the HFrEF, and for and ARNI, ACE, or ARB. And so you really want to have a safety assessment within 2 weeks, I would argue, and an up titration within 2 weeks, because the separation of the curves in terms of benefit, we start to see within weeks. And so you're doing a patient population a service by being aggressive and leveraging a disease management protocol linked with that type of follow-up of care.
Are your programs doing that?
Yeah. So for example, in Ohio Cleveland Clinic, we have a pharmacy touch point at post-discharge day 2 for med reconciliation, a mandate within 7-day follow-up for all patients as part of a discharge follow-up where you have a nurse practitioner and nurses to help optimize, and then a second point within the 30-day with the primary cardiologist or heart failure provider for ongoing optimization. And then it starts in the inpatient where you're leveraging GDMT to get them on board to minimize readmission. So it's linked in our system. All right, most excellent. We're going to move on. Thank you.